So we're really pleased in this keynote entitled Suicide Prevention, Science and Trends During COVID, to be hearing from Dr. Christine Moutier, who firsthand knows the impact of suicide, having experienced a number of colleagues going through the pains and pressures of life and ultimately dying by suicide. She's a leader in the field of suicide prevention and joined the American Foundation for Suicide Prevention as the Chief Medical Officer back in 2013. She's testified at the US Congress, spoken at the White House, and co-anchored CNN's Emmy Award-winning Finding Hope, as well as being an expert across a range of global publications and broadcasters. Christine, thank you so much for your time today. The floor is yours, and we'd love to hear more from you on the impact of COVID.
Thank you, Lee. And thank you also to Andrew McIntosh and to your leadership there, the planners of this conference, and really just incredibly esteemed colleagues. It's a bit humbling to follow that last panel. That was such a great discussion. So if it's okay, I'd like to share my screen so that I can have some visuals as I go here. Let's see. Okay, terrific. So I'll plan on presenting some comments for the next, let's try to keep it optimistic and tight for about half an hour. And please feel free to put your comments and questions in. I really think the value here is less about my comments and more about any discussion that this generates by way of what might be some observations you have in your locale, or as it pertains to kind of big picture strategy. So, okay, so let me get started. And just to disclose that I do work full-time as the Chief Medical Officer at the American Foundation for Suicide Prevention. I'll describe our organization here in just a moment. Two specific items to point out. The organization I work for developed and licenses something called the Interactive Screening Program, which is licensed to colleges, universities, and workplaces. And it is actually, on a personal note, the way that I became sort of introduced to AFSP about 20 years ago or so, when I was looking for an instrument to use in the academic medical environment I was working in at the University of California, San Diego School of Medicine at the time. Maybe I'll get more into my own personal experience here in a moment. And then also recently, just a few months ago, I published a clinical handbook called Suicide Prevention through Cambridge University Press, and the Steve Stahl handbooks that are mostly focused on psychopharmacology, but interestingly, we collaborated on this one that's much broader on preventing suicide. And the target audience of that clinical handbook is actually primary care health providers, as well as mental health providers, of course. But there is a lot going on in the US in primary care, and I'll actually get to that at the end of my talk. So just a word quickly about AFSP. We are what we call a leading nonprofit organization in the US. We say fighting suicide. Our mission is to save lives and bring hope to those affected by suicide. And we do that really based on being absorbed in the research community. We are the leading private funder of all suicide prevention and suicide research, probably globally. Now, that doesn't mean that, the National Institutes of Health here in the US are probably the largest funder, but from a private standpoint, that is AFSP. We also produce education, and we also do advocacy very directly at the federal and state level. And I think the really special thing, in addition to those aspects of our work, is that we are very connected to grassroots communities because we have chapters across all 50 states of the US. So it's a total of, I think we have 74 chapters now. So we literally have hundreds of thousands of people who are actively volunteering and involved with telling their stories, and in collaboration with our programming and our guidance from the national office. So we are an organization that is headquartered in New York City, but truly national in scope within the United States. And so there are some of our kind of mission critical functional areas. I didn't mention that in addition to the education programming that we produce, that I'll share some visuals of in the middle of my talk. We also have something through our programming efforts that's very specific to suicide loss survivors and has to do with really broadly creating a community or space for that community to thrive and to heal and get involved in any aspect of suicide prevention or postvention that they choose to, that can contribute to their own healing journey. And there are some very specific programming efforts and resources that we have in terms of suicide loss. Okay, so again, for the next several moments, I will structure my time by first just really covering a very broad spectrum of topics related to a sort of status update, if you will, on culture, some of the suicide trends we're seeing, and some of the areas of opportunity that relate to this very specific moment, 2 years post the start of the pandemic, maybe transitioning out of that possibly, but all of the other many societal factors that are going on, and kind of thinking through what do we know about suicide risk in light of all that, but remembering that suicide is not only related to these current events and so forth. There's obviously many factors within individuals internally and families, as well as these larger societal trends. And the last half of my formal comments will be about prevention strategies. And so obviously this is very ambitious to try to cover just some really kind of high level touch points about both these current trends as well as innovative prevention strategies. And the prevention will be looking at community-based, really that public health model for suicide prevention, and a very quick dip into clinical strategies. There won't be much time to go into that at all. But so just thinking about the current sort of really moment that we're in, but thinking about the couple of decades leading up to it, every couple of years, we as an organization co-sponsor a Harris poll. And so we've been sort of taking the temperature of attitudes and beliefs within the American adult population about mental health as well as about suicide. And what has been happening even pre-pandemic was an incredible trend towards an opening up, a reduction of stigma, and things like this first yellow box that really the data in the most current the poll that we took last year showed that 94% of American adults feel that their mental health is as or more important than their physical health. And similar trends in terms of belief about suicide being potentially preventable, an understanding that it's very multifaceted, but that it is not a sort of inevitable outcome, in terms of a public health issue or at the individual or family level. Now, we are all very well aware of all of the kind of surveys and measurements of distress and experiences that have been happening related to mental health over the course of the pandemic. And I'll just highlight one US specific resource that's really been an incredible source of data for us, which happened right at the beginning of the pandemic. Our CDC decided to start something new that they call the Mental Health Household Pulse Survey. And I was just looking at the data. They just finished their latest survey. So they've been surveying between 60 and 90,000 American adults almost every month. So it's quite an incredible effort. And they have several sections of this survey. It's about a 20-minute survey. But for example, American adults are being asked about their level of distress in terms of depressive symptoms, anxiety symptoms, but not only that. And so, by the way, you can look at that in terms of, by age grouping and by race, ethnicity, and by all 50 states in the country. So you can see how some of those trends are moving over the course of the 2 years of the pandemic, and tracking on any one of those levels of demographics that you're interested in. They also ask questions like, are you currently taking a psychiatric medication or in therapy? And that actually has been trending upwards. At the beginning of the pandemic, it was about 22% of the American population said yes to that question. Now it's over 26%. They also ask, have you been trying to connect with mental health treatment, but been unable to do so? And so that has been a concerning trend as well, that has trended up a tad, and it's sitting around 12% of the American adult population saying that they're trying to get treatment but unable. And so, of course, access to care is one of those tremendously important priority areas for us in the U.S., as I'm sure it is in most nations. So just a reminder that when we're talking about suicide risk and protective factors, we're talking about a very multifaceted, interactive situation where internal biological and psychological factors are interacting with current social and environmental factors, on a bed of genetic and epigenetic changes going on internally. And then current life happening, and of course, access to lethal means matters a lot. And so suicide risk is not, as I mentioned at the beginning, only related to pandemic or, kind of societal level trends that are going on. Of course, people are experiencing this on a very individual, the path to suicide risk is heterogeneous, with these sort of clustering of buckets of types of risk factors that oftentimes are present, and usually multiple categories, and even among the mental health conditions that put someone at higher risk for suicide, it's often the case that there are comorbid multiple mental health and physical health conditions oftentimes. So there are sort of these clusters in a way, but remember that it's very heterogeneous and very, very dynamic for any individual. So we don't think about risk in a sort of concrete way, and we certainly don't ever mean to say that, that a family history or genetics are destiny in terms of suicide related outcomes. That's not the case at all, but it is something obviously to be aware of, just like a genetic, family history loading for cardiovascular disease or any other complex health outcome. Towards the beginning of the pandemic, and I'm with some of the leaders of the effort of the International COVID-19 Suicide Prevention Research Collaborative, which I'm grateful to be included in. But Jane Pirkis and John David Gannell, many leaders, again, many of whom are here involved in this conference now, have been leading an incredible effort to be kind of surveying and doing real-time surveillance to every extent possible across multiple nations in terms of suicide risk. And so they have been publishing on that, and simultaneously, probably related to my involvement with that group to some extent, I was also invited to submit a paper for publication to JAMA Psychiatry. And this is just a visual that sort of tries to tell the story a little bit about that was very similar to a paper that the international group published as well, that really took a look at those societal sort of events that could be pressing on categories of types of suicide risk, where there are also preventive and mitigating actions that could be taken at a policy level or a health system level or a community level. And, so of course, again, this is very, multifaceted and different for different populations. We, though, at AFSP have been seeing some worrisome trends in the media where there were some, very sort of sensationalized predictions in a way, and even misstatements about suicide rates being on the rise at the beginning of the pandemic. And, it's not a super clear picture, but for example, when the Spanish flu pandemic occurred, this is data from the United States that showed that overall mortality did increase due to the flu, but suicide rates initially had an uprising and then a downgoing trend, so whenever there are natural disasters, pandemics, wartime, experiences like that affect an entire population together, there are different trends that can occur related to suicide, but our main point was to try to work with media organizations and other, community leaders to help them understand that suicide risk is not an inevitable outcome, even during a time like a global pandemic. We in the US have had this incredible outpouring of what I would say stigma reduction, and well-known actors, musicians, people of all different types of sectors who took that risk in a way to tell their own stories of either suicidal struggles, the experience of losing someone to suicide, or having another form of lived experience, which is having a family member who has struggled or attempted. And so, we think of this sort of lived experience and the use of self-disclosure, narrative storytelling. We think of it very broadly, that it could be about a mental health experience or a suicidal experience or suicide loss, and that this all can constitute a productive movement as a society in really understanding that suicide and mental health are true health experiences that can be disclosed, like we would other private health issues, obviously with using judgment and appropriateness, but that when we tell our stories, especially when there is a positive arc of healing and help seeking, that can actually have a contagious effect in the positive direction. So what we've been up to during COVID as an organization is really emphasizing a proactive strategy to mental health, coping, treatment, access to care, being connected to one another within families, across communities, promoting that sense that we're in this together. And so, it's interesting because we, like probably many of you, our platform affords the ability to both be on the media, messaging directly to the public, as well as working with leaders, workplaces, and media organizations more behind the scenes. And so this has been a really tremendous time of doing a lot of that. And in fact, over the last couple of years, by my count, we've had more than 200 national media engagements, and those are either on camera or through print or online types of media outlets. Our chapters also were accustomed to putting on the Out of the Darkness walks in person, and our programming that relates to suicide prevention education and suicide loss and healing, mostly in person. And that, obviously had to do a very quick transformation to virtual work, which has been accomplished, I think, very successfully. And actually, at the beginning of the pandemic, there was such a hunger on the part of workplaces and schools and faith organizations and policymakers to have this kind of content and for them to partner with us in putting it on and so forth, that our chapters got very, very busy. And so, of course, my national teams did as well in terms of producing that content and help assisting them with the technical support, putting it on virtually, especially. So that's been really incredible to see, but it wasn't a sustained thing. We saw that there was kind of a fatigue that occurred, sort of midway through, and certainly a fatigue with Zoom as well. The advocacy efforts that we've seen in the United States during the last 2 years are probably the most busy and productive than any other 2-year period in history when it comes to successfully passing legislation and certainly elevating the topics of mental health and suicide prevention very broadly. We have something that you might have heard about, which is that our main crisis line for the US, called the National Suicide Prevention Lifeline, is being converted to a 3-digit number like our 911 emergency system. It's called 988, but more than just a rebranding, it's really an effort to try to reform the crisis services response systems at the national, and of course, it really means at local levels across the United States. And that conversion to 988 is set to happen in just about 3 or 4 months in July. And we are frankly very worried because the system is limited, and all of those intermediary systems that we need to be in place, like mobile response units, mobile crisis response, that is, co-responders that are mental health professionals alongside law enforcement, or even, ideally responding frontline separate from law enforcement. Those are not yet built across the board. And we have a state-based legislative mechanism to fund those efforts, but only 4 of our 50 states have passed that legislation, which would allow for the collecting of telecoms fees, like taxes on, on our telecoms services. Just like does fund our 911 system, the same thing could be done for 988. But so anyway, we have a very sort of like pressing dire need in our advocacy world related to that, as well as many other things. We have been very fortunate to have, stigma reduction coinciding with the interest of, this is just a smattering of collaborators and partner organizations of ours at AFSP who got very interested in mental health and suicide prevention. And just to highlight a few here, obviously Instagram and some of the social media platforms are getting a lot of heat these days. Some of their teams have been working with organizations, and probably yourselves as well, to try to actually do good through their algorithms and offer resources. But at the same time, these are massive companies and have probably multiple, things going on. Not always sure the right hand knows what the left hand is doing. We're very proud of one partnership in particular, and that's with the American Academy of Pediatrics, because what has happened now, just 2 weeks ago, we released the first ever US national, we're calling it the Youth Suicide Prevention Blueprint, that the American Academy of Pediatrics worked with us on. And obviously the reason that is so important is it's now really calling to task primary care providers, including pediatricians, to become more trained in screening and care steps that can occur feasibly within primary care. And I realize that there may be national differences in these types of efforts. I think I learned that from Ann John at a recent meeting we were in together. So if that is a topic of interest, I would love to discuss that further. Just a basic comment here, because the science has advanced so much so that we do understand some of the underpinnings of suicide risk, and that it is a complex health behavior, if we can define it that way. And because of the voices of people with lived experience and loss, we now really clearly understand that the phrase commit suicide just does not make sense, because it implies a morally reprehensible act. And we don't use that for other health behaviors or outcomes. We don't say they committed cancer, for example. So we have had some advocacy efforts and obviously do lots of education consistently with all sectors around this. And the main sort of guiding journalistic entity in the US, the Associated Press Style Book, made this official change to recommend to all journalists to use the phrase die by suicide or other plain language, but just not commit suicide. And in the clinical world, we really try to avoid pejorative terminology or words that imply some kind of moral judgment like successful or failed. So these were some of those kind of headlines, and I think some of these were from the UK and some from the US. There was a period of time, you can see early on in the US, when our former president was, I felt, really using mental health and suicide as a sort of political vehicle in a way to accomplish, other agendas. And there was a very satisfying moment for me personally when I was the sort of fact checker for the Associated Press around that particular false statement that our president had made. But there were many things like this going on. So again, we tried to, as much as we could behind the scenes and on camera, just be sort of a steadying presence with some of the messages that I'll show you here in a moment. So what has happened in the US related to the national rates of suicide, and you can see that this is really going back several decades, just to show that for 20 years, almost 20 years, we had a very steady upgoing trend in our national rate of suicide from about the year 2000 until 2018. And then 2019 saw the first downgoing trend in a couple decades. And fortunately, 2020 is seeing the second consecutive year of a downgoing trend, another 3% decrease. It's not tremendous, but that it is significant actually. But the concerning thing, of course, like in other nations that we know from our international collaborative groups work, that it doesn't cut across in the same way across all demographic groups. And so in the United States, what this 3% decline is comprised of is a 2% decline among US males, an 8% decline among US females, and all age groups in the middle to older age groups showing a downgoing trend, but not for youth and young adults in the US. For young adults aged 25 to 34, there was a statistically significant upward trend between 2019 and 2020 of 4.5%, unfortunately. And for youth, between age 10 all the way up to age 24, young adults, there was a non-statistical significance with either staying the same or an upward trend in the suicide rate. And additionally, across race ethnicities in the US, what we saw in 2020 was Hispanic males and American Indian, Alaska Native, and Black males in particular did not see those same decreases. And so again, varying things, whether it was statistically significant increases or non-statistical significance, but basically not downgoing trends. And probably like in your nations, the same thing is probably true, that geographically there can be very dramatic differences actually. So this is just showing you a visual of one of the more recent suicide trend publications. Jane Pirkis, first author, and Anne John, very obviously very involved in the leadership of this group. And so again, it's been really an incredible experience. I'm so very grateful to these leaders for convening all of us on a monthly basis. It's been, I'm sure, very much a labor of love. And a pivoting of their energies and attention, but I think very, very fruitful to be able to come together as a global community of experts looking at the data and really thinking through various implications as well as policy implications. And so just to close out this section on sort of the COVID period, the data are somewhat reassuring, but again, some populations are not showing the decreases that many of the higher income nations data is mostly showing. And also these trends are very much evolving over the period of that 2-year period of the pandemic. And the international group is looking at them in sort of phases. So, but there are very significant silver linings, as was pointed out in the last session, that a sense of community cohesion and interpersonal connectedness on any level that can be palpably perceived by individuals in a population can have a protective effect. the normalized dialogue and the truly normalized experience of suffering and distress and uncertainty and everyone's schedules and worlds, sort of being turned upside down, I think has been very reassuring for many people who have had lived experience longer term. And I've heard some of them say that this was a period where they actually feel validated. And so connected, interestingly, to sort of the larger population for the first time ever. And I think we need to be really careful about what is happening as things sort of normalize in a way to make sure that every vulnerable group still feels that they are important and valued and being considered in policy and in programming development. Treatment seeking, as I mentioned, has been on the rise. Obviously, telehealth services kind of bursted open at the seams. In the US, that really meant very rapid legislative changes that allowed for the cross-state care of patient care that really had to kind of bust through these very, frankly, archaic laws that probably still need much more advocacy. In the US, we're trying to press very hard on the continuation of that openness and the access to telehealth services. But there is even the idea that that the way that, for example, our medical licensing takes place on a state basis in the United States should probably be considered to be handled at the federal level, because as you can imagine, the 50-state way of operating for certain things, including medical licensing, is a major, major problem, including for, by the way, physicians' own ability to seek care for our own mental health, because there have been such stigma and old school barriers that would even investigate a physician if they checked the box that they had received treatment for depression or anxiety. Just really, frankly, illegal, unethical practices that are still going on in about a third of our states. And I'd say the last silver lining or the last couple really do relate to that policy arena, as well as this incredible spotlight on health inequities, which have long existed for marginalized and minoritized populations, but which are now, I think, have taken on a level of priority, certainly within our organization, but I think across so many organizations and universities and workplaces. So it is a time all throughout the pandemic and continuing now that what we're trying to say is, to present the truth and these accurate messages, but really emphasize the need for suicide prevention strategies that are proven, that have demonstrated evaluation and implementation science, that those must be implemented to scale in order to continue to mitigate against these risks that are going on. Okay, in my last just few minutes here, let me try to cover suicide prevention strategies and do it somewhat justice, I hope. So at the community level, what we think about, because it might be very confusing, frankly, to the layperson, especially like suicide prevention at the community level, what does that mean? How do you, what does that tangibly look like? And so what I always start with is a framework to help ground everybody in this, the need to understand the public health model that can be applied to any health issue. And certainly among the top 10 leading causes, health-related causes of death in the United States, most of them have had a very significant investment in this public health model. That means an investment in research, an investment in universal education, public ad campaigns, school-based strategies, let alone clinical interventions and access to those particular treatments. All of those can be applied to suicide. And I think what I would say is the science has been growing. We're at maybe a toddler stage as a nation in the US at actually applying and implementing this public health model. We are far, far from anything that is to scale, although there are some really innovative examples at community or state levels. or for example, examples from our certain military programs or certain occupations. There have been sort of concerted efforts, but again, with suicide prevention, the issue is that if they're not sustained and built for a sustained funding source and a long time frame, then oftentimes what we know from the literature is that after a suicide prevention funding source dries up and the program stops, then suicide rates, which may have had improvements, oftentimes revert back to sort of pre-program levels. Now, these are some of the themes that are collected from a host of sort of, expert resources in the United States. That includes our CDC, which has a really wonderful technical package on suicide prevention, but other government and other groups like the National Institutes of Health and my organization as well. So these are kind of the cross-cutting themes that constitute evidence-informed suicide preventive practices. And the ones that are in pink there just really show that there are clearly some things that have been shown in the literature that relate to clinical care, accessing mental health care, feeling connected to that care, having efficacy with that care. But then now additionally, there are suicide specific treatments that I won't have time to get into today, but hopefully you're familiar with those CBT, DBT, various treatments that have been developed and studied with suicide risk reduction in mind. But then at the community level, you can see there are so many other things from the literature, like increasing interpersonal connectedness, reducing access to lethal means, infusing strategies that enhance resilience, coping, and problem-solving skills into schools, for example, or into more targeted vulnerable populations, like, let's say, an LGBTQ youth group that has an approach that is really looking to build up their sense of support. Identifying individuals and populations who are generally at higher suicide risk and providing them with more specific targeted support. Having an ongoing priority and a lens on equity and lived experience, and including that lens in everything that we do. I know that I'm preaching to the choir here. And certainly environmental, social, family, and economic supports. Obviously suicide risk is very multifaceted. And so the prevention strategies coming in to mitigate risk can be equally multifaceted. We have a saying in suicide prevention that is postvention is a form of prevention. Because we really believe that from the data, that after the experience of losing a loved one, or even just the exposure of a peer, sometimes even a celebrity, when it's messaged in a particular way to suicide, can elevate the risk of those loss survivors. And so postvention efforts are really critical, especially in the period of the acute aftermath of a suicide death, that a workplace, a school, a college, university, a faith organization can employ that will mitigate the risk for contagion and will allow for healthy grieving and that community cohesion that can happen during a period of loss when there's appropriate leadership and appropriate language that treats the suicide death in a way that is accurate but non-sensationalized. It is very nuanced, obviously, because you also need to have family permission to do so, in certain environments. So we at AFSP do have lots of guidance and toolkits around that postvention period. Okay, I'm going to just skip through some of these details since I've talked about a lot of it already. I'll just highlight here that at the state level in the United States, there are, you may have heard about an unfortunate sort of political polarized war that's going on right now. I shouldn't use that word, but related to especially trans youth, but LGBTQ youth. And so AFSP is involved in this very squarely. We have been for years in terms of speaking out against conversion therapy, but now the anti-trans legislation is quite rampant in certain states. And so that is one of many priority areas. So let me just give you the visual on a few community-based suicide prevention efforts that we've either developed or we're involved with. And if there's time, I'll mention Project 2025 and a snippet on clinical approaches as well. So when we do education to any community group, age appropriate, because we still are of that mindset that we're not promoting direct suicide education to students and youth that are younger than about age 14. And that of course varies depending on the context. But for young adult and older adolescent and adult populations, we really do educate about suicide being a complex health issue. And again, context specific, we might include some of these top scientific findings from the very, very exciting field of suicide research that we love and support so much, and have very specific strategies around growing that field and mentorship and so forth. So a sampling of some of our resources and programs, for example, are here. We've done something that I'm very proud of, but did stir up a little bit of misunderstanding, which was to engage with a firearms trade organization, the National Shooting Sports Foundation. They are not the NRA. Their members are the businesses in the firearms arena, to produce suicide prevention education that would come from within their community. So it can be embedded in firearm safety courses and be, showing videos within a retail environment or a gun range, for example. So our culture at AFSP is to be always squarely evidence-based or evidence-informed, but I would also venture to say that we are opportunistic in the sense that if something can have a potential impact on reducing suicide risk and rates, we will consider doing it if there's a readiness and a likely outcome that's related to our mission. And that allows us to have a nimbleness in terms of how we approach this. And now remember, we are across all 50 states. So that means we have volunteers and people involved in our organization on all sides of the political aisle, but with the common ground of this incredible passion for preventing suicide. These are just some of our school-based resources. We love partnering, and so we had partnered with some other school-based national associations to produce something called the Model School District Policy on Suicide Prevention. I think this remains the gold standard for K-12 school districts when it comes to them having a guide to build their own suicide prevention policies, protocols, trainings for staff, et cetera. We collaborated with the Ad Council and the JED Foundation, another American group. The JED Foundation is involved in suicide prevention on college campuses, to produce this ad campaign called Seize the Awkward. And I think, you have to, the target audience for this are 18 to 24-year-olds, which, they helped us design this campaign, but it was really based on the idea that young people know when a peer is struggling. And we knew from other data that oftentimes the suicidal individual does not tell anyone about their suffering. And when they do share and disclose, they may only share with a peer. And so this was really meant to help equip young people to be that they valued their identity as a friend and felt very strongly about doing something, but felt they didn't have the skill set. And by the way, that ad campaign has been going on a couple years now. Instagram is one of the primary places, but TikTok has signed on as well. And what has happened is influencers like Billie Eilish get involved and tell their mental health stories and promote the campaign. And so for those reasons, it has been able to reach, the Ad Council tells us 52% of young people have seen this campaign. We produce programs, and one of the most recent ones we did that I'm really proud of, being somebody who has been personally not only touched by suicide loss, but I have young adult children. I have family members who have been going through their own struggles. And again, our network out there in the chapter world means it's all of these types of experiences. And we realize that education to families and friends and colleagues for how to support someone who has had an attempt or is having a suicidal experience. There really was not a lot out there of that kind of education. And so you are most welcome if anyone's interested in going to our AFSP programs calendar. You can just search that and you'll come up with a whole host of virtual programs that our chapters are putting on, including this program. We also have partnerships and a lot of work going on with workplaces. And I won't have time to get into most of this, but it's really an incredible time when a large health company like Aetna CVS Health has made suicide prevention an actual priority in a very sort of multifaceted way. We've had a long-standing priority on healthcare professionals' suicide. That is how I came to this work myself, was through the loss of a number of physician colleagues to suicide at UCSD. And so if you're interested in that particular type of population and work that's going on, there's a lot going on in the advocacy space, but we have a section of our website that's devoted just to healthcare professionals. We wish we could do the same for every occupation. We do work with probably every occupation, but this has been like a 30-year build in terms of health professionals. This is a sampling of our toolkits for after a suicide. I mentioned about postvention. So know that it exists for K-12 schools, but also for some other environments. The American Medical Association worked with us to create their own after a physician suicide toolkit. So that was really, again, a signal that very mainstream health and other organizations are really getting involved and taking this on. That's one of our sort of philosophies at AFSP is we're a decent sized nonprofit, but small in the grand scheme of things. And so we rely on partners, to really carry this forward. Okay, I'm going to have to unfortunately close my comments. I'll just end by saying that that there is something going on in the US that may not be going on in other countries, which is that there's some consensus around standard minimum steps to take in terms of identifying suicide risk in clinical settings. And I'm not just talking about behavioral health settings, but primary care and emergency care as well. And so these sort of basic steps are now being implemented within large health systems in emergency departments and in primary care that hopefully coordinate with behavioral health. But this is something that is a very hopeful sign to us that implementation is happening. It is humbling in the sense that we don't know everything, and not that implementation science field is not complete yet. Not that science is ever complete, but so I present this humbly, but I was interested to know if things like that are happening in your areas as well. So I'm going to go ahead and close my comments with that. That's a visual of my clinical handbook, and I'll stop there.
Brilliant. Thank you so much, Christine, for that presentation. I've got a flurry of questions that's come into my direct messages. We've got a few minutes, so I'll try and cover them off fairly quickly. So one question that's come in is around, you mentioned sort of surveys and studies that have been done at US governmental level to sort of assess mental health. And one of the challenges we've all been wrestling with in the UK is how to make studies more representative of those from low socioeconomic backgrounds and minoritized communities. In your work, have you got any sort of points of success in trying to improve that representation?
I think we as an organization are in that process of building those strategies right now. So we do not have all the answers, but what I will tell you is we have been actively listening and really elevating their voices. So we do that through a whole host of sort of strategic efforts, but we're very, very serious about, getting that feedback from minoritized expert groups? Are we being collaborative? Are we being a true learning organization? And are we attributing, back to you and sharing that developmental process? We're going through that with several programs right now. I have a town hall series that is called Elevating Voices. So it is not a simple matter, but I'm really, really glad that it is happening now, and at least our effort is full-fledged. We, again, we're not terribly expert on this, and it was a very humbling moment to realize that.
And I suppose the thread of the day, if you like, we started this morning looking at what were the trends in suicide through the pandemic, and I suppose coming all the way through to the conclusion of your talk. For me, it's highlighted the link again between the gathering and use of data through to how then we turn that into, as AFSP has done, high impact improvement of suicide literacy, promotion, prevention. Suicide trends, as we've sort of discussed today, are often paradoxical. So at times of sort of global pressure, we've seen decline. As we move, hopefully, into prosperity, there's a curve in the other direction. How do you ensure that the prevention strategies that you're trying to implement get cut through at a time when the rest of the world is just happy to be out of the chaos? How do you continue to get that cut through when the world stopped panicking about suicide?
Yeah, well, that's such a big question. I think we generally try to do this by building relationships that are deep and sustained in the policy arena, so that, if your group or your coalition group together can continue to be that trusted resource, so that there is a true two-way dialogue. And, I will say, I think we have been able to do that to some extent, because even while attentions, sway towards other things, which they always do, we continue to be turned to, whether it's behind the scenes or to do, congressional testimony to help draft legislation, things like that.
Brilliant. And a final question then that's come in, and then I'll hand back to our chair, Andrew, to give us final remarks. In the UK, we were talking earlier about data mined and this sort of effort to unify mental health data across the UK, but also make it an international resource. And you've mentioned a few collaborations internationally. What do you think we can learn here in the UK from the work you do in the US about how we build those collaborations and put data to work in preventing suicide and self-harm?
I think that it's not a simple matter. And in fact, there's quite a bit of controversy, even to this day, amongst the scientific community in the US, at least, that we're a little split on the issue of having a universal approach to data collection, for example, because it does depend on the context. But that said, from the big picture in terms of suicide surveillance, I think we can all agree that that is a high priority need to become more accurate and more timely. And again, for us, that's not something we would have control over, but we can influence our main body in the US, the CDC, and the National Violent Death Reporting System, which is a subset of that, has been a very specific point of advocacy focus for us. So I think it's kind of building a way to have sustained, again, relationships, effort, and influence with partners.
Brilliant. Fantastic. Thank you so much, Christine, for all your input. I really appreciate it.
Thank you for having me.
Thank you for your expertise. It's been fantastic having you join us today.